بسم الله الرحمن الرحيم. اللهم صل وسلم على سيدنا محمد وعلى آله وصحبه وسلم. My name is Ahmed Edreas and I'm an orthopedic oncology consultant. We're going to talk about soft tissue sarcomas, then we're going to open the gate for possible questions if you have, and if you have time we can even practice on how to read x-rays, which for me are very important. We can have practice sessions. والعدد I think is a small number. ما خاب ظني خلينا بس 12. حلو. طيب نرجع للسلايدز حقتنا. طيب okay. طيب so as a general rule, the most common presentation for a soft tissue sarcoma is an enlarging, they say painful or painless soft tissue mass, but most commonly it's a painless soft tissue mass. Painless, no pain with soft tissue sarcomas most of the time. And this is the most common presentation. On MRI for soft tissue malignancies, usually they have a pseudocapsule surrounding it, and most of the time it's heterogeneous. There are two, let's say, counterparts. It's either for any mass, it's either homogeneous or heterogeneous. Homogeneous is a good sign. Having a heterogeneous mass, this goes with a worrying lesion. Okay, we're gonna show examples of both. As a general rule, for any mass larger than 5 centimeters deep to fascia, it should be considered a sarcoma unless proven otherwise. Okay, for soft tissue sarcomas on MRI, in all of the books, all of the textbooks, all the literature, on T1 it's always low, on T2 it's always high. Okay, and if there is contrast, and most of the time there is, it's going to be enhancing. Some areas are not going to enhance, which is most likely the necrotic part of the tumor. But for an easier way to remember this, okay, I used to do this and I used to forget it. I used to confuse which one is high, which one is low. Is it T1? Is it T2? I always forget. But to make it simpler, let's see, for example, this MRI. Don't focus on the talk, just look at the picture. Okay, so we have a mass on the lower picture, this one. So this is a mass and this is fat. So here the fat is bright and the bone marrow is also bright. And the soft tissue mass, this only applies for soft tissue sarcoma. So if we apply the rule, which is low on T1, so this mass is low on T1. Okay, so let's go to the other picture, this one. So this is, the fat is bright and fluid is bright. Sorry, that fat is dark, bone marrow is dark, and the mass is bright. The fluid inside the mass is bright. Okay, so let's go back. Sorry, I confused you. On T1, fat is bright. As the rule says that tumors are low on T1. On T2, H2O is bright. And the rule says that on T2, the tumors are bright. So an easier way to remember it is that to look on the soft tissue mass and the bone. If they are opposite to each other, then the rule applies. This is not in textbooks. This was my freak association that I made, but it applies in exams because they always show you two cuts, T1 and T2. They don't show you other slides. They just want you to have the concept of understanding what's a concerning image. But for me, a message to you, you should always understand T1, tumors are low. T2, tumors are bright, sarcomas, okay? how to associate it or how to remember this rule. So I made this freak association only to remember the rule, okay? Because fat is bright on T1, and tumors most of the time, let's say most of the time, don't have fat. So opposite to each other. On T2, tumors are always have fluid in them, so most of the time they are bright. And the cortex has no bone. Sorry, the cortex has no fat and no fluid. That's why the cortex over here is dark. Go to T1, cortex is also dark. But bone marrow has fat. That's why we have fat embolus. So medulla has fat. Subcutaneous fat is bright. Medulla is bright. No fat. Medulla is dark, let's say in relationship to the cortex, in relationship to the subcutaneous fat. So consider this a T2. So no fluid in the medulla and no fluid here, but there is fluid over here. Okay. دقيقة سامحوني. Let's go back to 127. Right. For metastatic workup, for all soft tissue sarcomas, we usually include chest x-rays because this is what we're going to do for every visit for the patient, and CT chest and nuclear scans. But for some rare diseases like myxoid liposarcomas, we usually include CT chest, abdomen, and pelvis. Why? Because they can have sometimes atypical metastasis or atypical sometimes liposarcomas, where in the retroperitoneal. And this can be missed with ultrasounds. And in new literature, they say that chest, abdomen, pelvis is not enough. They can even miss lesions which are in the appendicular skeleton or limbs, upper limbs, lower limbs. So they say for myxoid liposarc, whole body MRI. It's not yet in the books, but for your exam purposes and your let's say residency, myxoid liposarcoma staging includes CT chest, abdomen, pelvis. For all of soft tissue sarcomas, we usually include only CT chest, but myxoid liposarc, CT chest, abdomen, pelvis. And this is an MCQ question. Okay, and this is an MCQ question. This is an MCQ question, and this is also an MCQ question. Another way of having an MCQ for this one is that when they ask you what would you, they will bring you an MRI and they will tell you what's the appropriate biopsy for it. مثلا لو كانت أقل من 5, if it's less than 5 centimeter above the fascia, let's say if it's 1 centimeter above the fascia and away from the neurovascular bundle. Okay, usually we started taking core biopsies, but the needle is like 1.5 centimeters, and usually it sometimes overshoots. يعني تخش التومر احيانا لو كانت الابره 1.5 سنتي والورم كله على بعضه 1 سنتي، الابره اكبر من الورم. فعشان كده what we do is that we take it as an excisional biopsy. ناخذ الورم بكبله, take it out, send it for histopath. This is another way asking the same piece of information, but in another way. What would you do an excisional biopsy for? Lesions which are less than 5 centimeters away from the neurovascular bundle and above the fascia. Okay. طيب. Unplanned removal of soft tissue sarcomas is the most common error. Unplanned excisions. This is the most common presentation of referral for patients for soft tissue sarcomas from other departments, without saying names. But, and the MCQ that usually comes is that unplanned excision, what would the next possible step to do? They want you to say that this is an histopath came back as a sarcoma, soft tissue sarcoma. The appropriate answer is you should take wide margin tumor bed, wide margin re-excision. So they want you to understand that a soft tissue sarcoma which underwent unplanned excision with positive margin should undergo a wide margin excision. Okay. Okay. So the most common soft tissue sarcoma of the hand is epithelioid. Of the foot, soft tissue sarcoma, the most common one is synovial. You should always remember translocation for each one. Synovial is TX18. This always comes in exams, okay? The primary site of MITS from soft tissue sarcomas is lung. The primary site of bony sarcomas is lung. So if the question comes, what is the primary site of metastasis for sarcomas? It's lung. The most common site of soft tissue sarcoma MITS is lung. Most common bony sarcomas MITS is lung. Okay. But in bony sarcomas, we usually do chest, abdomen, pelvis, especially if the patient is more than 40 years of age, but because it includes a working حق MITS carcinoma, thyroid, breast, lung, renal, and prostate and breast. Right. This is an MCQ question also. Some soft tissue sarcomas have lymphatic metastasis, okay, which occurs in 5% of the cases, and they are included in one word, which is ESARC. E for epithelioid, S for synovial cell sarcoma, angiosarcoma, rhabdomyosarcoma, and clear cell sarcoma. Okay, epithelioid is the most common sarcoma of the hand. Synovial is the most common soft tissue sarcoma of the foot. Angiosarcoma, it's a vascular lesion. Rhabdomyosarcoma is the most common soft tissue sarcoma in pediatric patients. And clear cell proximal femur. Anyway, clear cell sarcoma is another lesion with lymphatic MITS. Okay. Rhabdomyosarcoma is a soft tissue mass, and we said the general rule for soft tissue mass is wide margin plus minus radiotherapy. Okay, but for rhabdomyosarcoma, there is it responds well to chemotherapy. Okay, so there are exceptions for the rule. As a general rule, soft tissue sarcomas, wide margin and radiotherapy. Tamam? As a general rule for bony sarcomas, neoadjuvant, wide margin excision, reconstruction, and adjuvant therapy. Some bony sarcomas respond well to radiotherapy, like Ewing sarcoma. Okay, so there are exceptions for every rule. Right. Tumors of fibrous tissue. Tumors of fibrous tissue, which like desmoid tumors or desmoid fibromatosis. أكيد أغلبكم سمعتوا عن palmar fibromatosis and plantar fibromatosis. Those are benign entities and those are not pathological. While desmoid fibromatosis is a pathology, and it's sometimes or most of the times it becomes painful. And that is when the patient usually presents to you, and sometimes they present to you with, like it says, rock hard masses. You feel it, you tap it, it's rock hard. The patient starts to complain of pain. Imagine you having a rock moving, or let's say walking with a rock in your leg or a rock in your thigh. It's very painful, especially if it's inside the muscles. And it presents usually with masses, which are desmoid fibromatosis. It presents with masses which are very locally infiltrative. It's a benign entity, but it's very much aggressive locally. تمام. So نرجع لهذه. سوري عشان بس تنتبهوا لي هنا. So this looks like a normal tibia x-ray, but again, here, this has a big mass over here. Okay, desmoid fibromatosis, sometimes they have syndrome. So some patients who are diagnosed with desmoid fibromatosis, we send them for the medical oncologist for further screening. Sometimes they have colorectal cancer, and sometimes they have Gardner syndrome. Gardner syndrome have a 10,000-fold increased risk of such tumors of desmoid fibromatosis. So it's again, this is an MCQ question. Like, for desmoid fibromatosis, they respond well to estrogen receptor inhibitors, or let's say hormonal therapy. Wide margin surgical excision is still, it's still in the literature, it's still in the books. Sorry, still in the books, but not in literature. It's not advisable. I don't recommend. I've never touched a desmoid fibromatosis desmoid fibromatosis for surgery. We always send them for radiotherapy, hormonal therapy, but we don't touch them because, again, it's very locally aggressive and it's very much infiltrative. And once you touch the lesions, they become more and more aggressive. So you take a wide margin, it comes back as negative, and it comes later on, the patient develop a recurrence and it's more aggressive than the previous one. And you undertake another wide margin, which is worse than the previous one, and the patients are never happy and the results are never satisfiable to the patient. So, but for your teaching purposes, desmoid fibromatosis responded well to hormonal therapy, and the treatment is wide margin because they are locally aggressive. They're benign lesions, but they're locally aggressive. Right. Nodular fasciitis. If you remember the rule that we said on T1 for soft tissue sarcomas, they are low. On T2, they are bright. Okay, so nodular fasciitis is a benign entity, but sometimes it's painful, very rapidly enlarging mass, usually in young patients, 15 to 35, and the treatment usually is marginal excision. But we cannot do marginal excision unless you have a diagnosis, because we said it's, let's look at this. This is T1, and if I'm not mistaken, yes, right. خلينا نشوف. I can't move it, سامحوني. طيب أحتاجكم تطالعوا هنا في هذه الحتة تحت الأخضر على طول، تحت الماركر هذا الأخضر في حتة بيضة in the middle، حتة بيضة في وسط المسلز. This is bone. فعندنا subcutaneous fat وعندنا bone والmass opposite to bone, opposite to fat. This is T1. The middle picture, this is T1, and the mass is opposite. The mass is low on T1. The rule applies. This is soft tissue mass. T1, it is dark. T2, it's bright. And with contrast, it's enhancing. It's totally enhancing. بس أنا جبت لكم سلايد واحدة عشان أبغى البون كان معاي. Just for your teaching purposes, let's say. The rule applies. It's dark on T1, bright on T2, and it's enhancing with contrast. So this is concerning for sarcoma, okay? But if you remember, we said a concerning feature is heterogeneity. A less concerning or a benign feature, which is homogeneous, okay? So this lesion is homogeneous. It looks like it's one large fragment. This is in T2 and this is in T1. It looks like one large fragment, okay? طيب تعالوا نشوف هذه السلايد. It looks like it has multiple fragments inside, okay? صح ولا لا؟ تمام. It's not like one piece. No, it's like pieces that have fragmented inside. And if you look at all of the tumors, سواء هذه السلايد أو هذه السلايد أو okay لسه ما في سلايد تانية جاي، فكلهم surrounded by something called a pseudocapsule. كلهم surrounded by a pseudocapsule. okay? Whether they are benign or malignant, okay? They always have a pseudocapsule, and this capsule, and another feature which is differentiates soft tissue sarcomas and carcinoma زي مثلا thyroid cancer, breast cancer, lung cancer, breast cancer, all types of carcinoma, they can have skeletal mets. Okay, so other than the primary site, يعني عندنا مثلا breast cancer بس عندهم مثلا proximal femur mets أو distal femur mets على سبيل المثال. Whenever they have a soft tissue part or a soft tissue lesion or حتى bony lesion, usually it's bony lesion and it goes out into the soft tissue part. It's invading. It has no respect to surrounding anatomy. بمعنى التومر ممكن يطلع على anterior compartment of the anterior compartment of the thigh من البون للانتيريور compartment، بعدين في نفس الوقت انزل للposterior compartment. تمام؟ بس this is a feature of مثلا carcinoma. But لما تيجوا للساركوما, sarcoma are respectable tumors. They always stay within compartments. If the tumor is inside, for example, a soft tissue mass within a compartment, it always spreads up, down within that compartment. تمام؟ فأوريكم sorry نبغى دي حنيجي فهذا السلايد اللي بعده. So if you look at this x-ray, the tumor is within one muscle. Okay.
يا دكتور أحمد الصوت معلش الصوت مش واضح.
دكتور أحمد معانا؟
آخر شيء
كنا في السلايد اللي بعدها عند differentiated.
طيب بس أنا عارف بعيد وزيد فيها. Low T1, high on T2, this is concerning for sarcoma. Nodular fasciitis is a benign entity, بس زي ما انتم شايفين في ال MRI. T1 it's dark, T2 it's bright. حتى لو كانت homogeneous, it's still concerning because it's more than 5 centimeters. The MRI picture or MRI appearance حقها is concerning for sarcoma. It's enhancing on with contrast. And an easier way to remember the rule of low T1, high T2 is to look on the bone. If it's opposite, that means it's concerning for sarcoma. Tamam? Opposite to bone, this is not in any textbook. And this is my association to remember the rule of low T1, high T2. Keep it in mind. طيب, undifferentiated pleomorphic sarcoma is the most common malignancy, soft tissue malignancy in adults. And to be honest, it's the most common soft tissue malignancy I've operated for the past 2 years. Again, low T1, high T2. Treatment for any soft tissue sarcoma is wide margin excision plus minus radiotherapy. Okay? Whether pre or post-op, often whether neoadjuvant radiotherapy or adjuvant radiotherapy, usually it's a surgeon preference. or center preference, let's say, and sometimes the patient's overall condition dictates whether or not we can give at times. Like fibrosarcoma. Again, MRI is the same for any other sarcomas, which is low T1, high T2. The amount of homogeneity or heterogeneity. The more homogeneous it is, the more likely it is to be less aggressive. Even if it's a sarcoma, the more likely it is to be less aggressive, okay? The more heterogeneous it is, the more likely it is to be more aggressive, as a general rule. So fibrosarcoma, again, it's a sarcoma. So the treatment is wide margin excision plus minus radiotherapy, okay? Long-term surveillance, because they have a chance of recurrence on all of them do. Like tumors of fatty origin. Most likely, this is the most common tumor that you will face. Anything else you will refer, but sometimes for soft tissue sarcomas, often for lipomas, you can diagnose yourself and don't treat them. Just keep them. And again, if you refer them, no oncologist is gonna refuse a mass. If you refer it, most likely you're gonna refer it as a large mass concerning for sarcoma. We're gonna take it, investigate it, and then either reassure or do surgery or whatever. We're gonna take charge in the end. But lipomas are very easily diagnosed, okay? MRI, they look the same as mature fat on all sequences. Look at this sentence, mature fat on all sequences, all of them, okay? So we're gonna repeat all of what we said. Okay, so lipoma, on T1, you look at the fat, subcutaneous fat, and you look at then the mass. Is it the same signal? Yes. Like, is it homogeneous? Does it look like one piece, one large piece, or does it look like it has pieces inside pieces or like fragmented? Okay. No, it looks like one large piece. Intramuscular, yes, it's within the muscle. This is the muscle, but it's one large piece. Okay, let's go for T2. It's one large fragment. It's homogeneous and okay, the signal is similar to fat. Look at this and look at this. Okay, when we go to this image, most likely this is T2. Fluid inside the joint is bright, so this is T1 fat suppression most likely. But this is T2, fluid inside the joint is bright, and the fat or the tumor is dark, and subcutaneous fat is also dark. So T1, T2, T1 fat suppression, they all look the same as subcutaneous fat. So it's a lipoma. And but again, for lipomas, you have to scroll through the whole MRI. If you have any heterogeneity, any concern or any classification inside the lipoma, these are concerning for a liposarc. Sometimes for lipomas, you can have a very large lipoma, but a small segment of it. خلينا يعني أوضح لكم هي. This is all a lipoma, تمام؟ وهذه كلها lipoma. وهذه كلها lipoma. أحيانا في بعض liposarcomas, they're all lipomas. يعني في أغلب الكتلة وأغلب most of the mass is a lipoma. But a small part of it, حتة مرة صغيرة, تلاقوا فيها مثلا calcification أو تلاقوا فيها شوية heterogeneity. The remaining part, it's all homogeneous, all going with sequences of mature fat on all sequences. But this part is not. فمعناته هذه كلها في الغالب لايبوما إلا هذه الحتة. This is concerning for sarcoma. معناته لو جاء الإنسان بياخد biopsy, does he have to biopsy this part or this concerning part? هذه الحتة. فعشان كده most of the time for lipomas we don't biopsy. لأنه عندنا high chance of let's say error. فعشان كده إذا كانت في most of it is benign, most of it is benign looking or benign appearance, but small part of it is concerning for a malignancy or sarcoma, we take it out as a marginal excision. زي هاي myxoid liposarcoma. Most of this is fat, but this area is concerning. لما نيجي نشوفها في هذه, this is with contrast. See, this is all enhancing. سامحوني, هذه كلها enhancing. هنا عندنا هذه vessels, it has fluid in them, فهذه غالبا with contrast, but this is all enhancing. Lipoma should not enhance. تمام. lipoma عادة يصير عندها something called ring artifact. يصير عندنا ما في. طيب خير. يصير عندنا enhancement بس على البريفري حق اللايبوما. بمعنى تيجي تشوفها في T1 تلاقيها bright, تيجي تشوفها في T2 تلاقيها dark, تيجي تشوفها في T1 fat suppression مثلا تلاقي subcutaneous fat is dark وتلاقي اللايبوما is dark, بس عشان فيها contrast تلاقي حوالين الماس enhancement. بمعنى تلاقي حوالين الماس في عندك bright ring, دائرة بيضاء. نيجي نتكلم عن الميكسود liposarcoma. Mixed liposarcoma في عندك we have the translocation is very important to remember. Another thing to remember about myxoid liposarcoma قلنا ايش؟ اللي هو it requires CT chest abdomen pelvis to rule out retroperitoneal myths or retroperitoneal synchronous myths. بمعنى ممكن المريض يكون عنده حاجة في الثاي بعدين ممكن at the same time يكون عنده synchronous myths في ال retroperitoneal area. For exam purposes, at your level, CT chest abdomen pelvis or myxoid liposarcomas. Even for most of, let's say most institutions, they are trying to apply, for example, whole body MRI. Right. These are images of the same myxoid liposarcoma that we just saw. This is T1, T2. هنا عندنا كمان ال heterogeneity is here. طيب. And this is with enhancement. برضو نفس الشيء. طيب. Liposarcomas زي ما انتم شايفين it's subcutaneous. It's not homogeneous بمعنى ما هي كتلة واحدة. في عندنا this is fat, this is close to this signal, but this signal is not the same as this signal. فمعناته this is concerning for sarcoma. لما نيجي نشوف في T2 it's like it lit up, ولعت زي اللمبة. This is concerning for sarcoma. Liposarcoma is the most common soft tissue sarcoma, second most common sarcoma in soft tissue sarcoma in adults. The most common is undifferentiated pleomorphic sarcoma or UPS. It virtually never occurs in the subcutaneous tissue, but it does happen. I've seen it. And as you can see here in this images, it's in the subcutaneous fat. So MRI demonstrate a thicker, more irregular septa. Tamam? And it also appears bright on T2, which is abnormal for a lipoma, correct? Lipoma, we said, it goes with fat. T1, fat is bright, فحتكون lipoma bright. T2, H2O bright, and lipoma does not have any fluid in them, they will be dark. Tamam? If you understand the rule of T1, fat is bright, T2, H2O is bright, and you're thinking about fat, so apply the rule, it should go. If it does not apply, it's concerning. But tumors of neural origin. Neurofibromatosis. They can have either one neurofibroma or a plexiform neurofibroma, multiple neurofibromas. Sometimes they can have when we say plexiform, they can have multiple masses along a specific nerve. مثلا يمسكوا في الشورال nerve أو يمسكوا أحيانا في sciatic nerve. We sometimes balance it. If the nerve is like the sciatic nerve, it's a major nerve, and the patient is not willing to lose the function of it, if the patient can survive the symptoms, we keep it. But what's more concerning is that if the patient has a neurofibromatosis with cafe-au-lait spots, lish nodules اللي هي تكون في الإيرس. lish nodules اللي أحيانا تكون في الإيرس and anterolateral tibial bowing. This is concerning. And usually for neurofibromatosis, NF1, they have a chance of malignant degeneration, and they can have malignant peripheral nerve sheath tumor. تمام. neurofibromatosis من يوم ما تشوفها لازم تربط في دماغك، أو يعني دماغكم كلكم الله يحفظكم إنه neurofibromatosis NF1. Tumor of malignant neurofibromatosis is malignant peripheral nerve sheath tumor MPNST. اسم طويل أنا عارف، معليش. فالتريتمنت حق malignant soft tissue malignant peripheral nerve sheath tumor is the same. It's a sarcoma at the end. It's wide margin. تمام. If it's within the nerve, that nerve has to go, right? With a wide margin, of course. And if it's a soft tissue sarcoma, plus minus radiotherapy, it depends on each patient. Adjuvant, neoadjuvant, it depends. طيب muscle tissue، يعني انا حطيت لكم الام ار ايز في البدايه بس على اساس انه يكون عندنا examples، بس انه باقي ترى للامانه it's all knowledge للاسف. It's heavy condensed بس تحملونه. rhabdomyosarcoma, it's the most common soft tissue sarcoma in children. Again, in pediatric patients, soft tissue sarcoma in pediatrics, it comes in the head, neck, genitourinary tract, and retroperitoneum. Extremity, this is our part. Head, neck, genitourinary tract, retroperitoneum, we don't deal with it. We deal with extremity. فأحيانا يكون عندك alveolar type rhabdomyosarcoma في translocation اللي هو translocation 213. الجين تايب عادة ما ننسأل فيه، بس دائما ننسأل في الترانسلوكيشن اللي هو T213. تمام. rhabdomyosarcoma is sensitive to multi-agent chemotherapy. احنا قلنا any soft tissue sarcomas التريتمنت حقها حيكون عبارة عن ايش؟ wide margin plus minus radiotherapy. But rhabdomyosarcoma, it's sensitive to multi-agent chemotherapy. So sometimes they do take chemotherapy. But treatment for any sarcoma, wide margin plus minus radiation. Okay, leiomyosarcoma treatment is the same, wide margin plus minus radiation therapy. An image, it's the same as any sarcoma. Low T1, high T2, heterogeneous, enhancing with contrast. These are all features of sarcomas. تمام. Hemangiomas, vascular lesions. طيب, usually as we said, أو زي ما قلت لكم, soft tissue sarcomas, they respect boundaries. If it originated within a muscle, it spreads within that muscle, proximal, distal, until that muscle fails, until it has exhausted the muscle. The muscle can no longer contain the tumor. It goes or spills outside of the muscle. But it goes up and down within that muscle. It stays within the compartment. It stays within facial plane. تمام. vascular tumors. بس في نقطة تانية. Soft tissue masses usually don't cross joints, or sarcomas in general, they do not cross joints. بمعنى إذا كانت في proximal femur, it will not go into the acetabular part unless it's very, very, very late presentation and it's very much of an advanced disease, but it's an unusual presentation. If you see if you see a mass or any tumor that's in the proximal femur, for example, and going to the acetabular part, think about infection, think about vascular tumors, or حاجة دحين حنقولها برضو. طيب, vascular tumors زي hemangiomas, they are common in children, adults, and radiograph may reveal phlebolith. Phlebolith, this is a common MCQ question. يديكم الاكس-rays ويقول لكم what is your differential مثلا. يحط لكم Ewing, osteosarc, osteosteoma مثلا, ويحط لكم واحدة من الليجنز تكون vascular. Vascular lesions or hemangiomas, they can have phlebolith. For multiple hemangiomas are usually associated with Maffucci syndrome, and Maffucci syndrome have 100% chance of malignant transformation. This is another MCQ question. Okay, so this is a vascular lesion. These are hemangiomas, and you can see some calcification within the and it can have what's the soft tissue, it's just lying there. Once you see calcifications like this and this is, you should suspect a vascular lesion. Plus, if you look on the haziness of the shadow, there's something over here. Okay, so usually sarcomas, they don't cross the joints. Okay, if you do see something, if you do see a soft tissue lesion that is crossing a joint, think about vascular lesions or infection or atypical infections, brucella, TB, okay, mycoplasmosis or حاجة زي كده. بس إنه phlebolith, think about vascular lesions, hemangioma, تمام. Angiosarcomas is associated with Stewart-Treves syndrome. Cutaneous and lymph node metastasis is common. Treatment, again, wide margin, plus minus radiation. Synovial disorders. فإحنا قلنا lesions that can cross the joint is what? Vascular, infection, synovial disorders. هنا شوفوا لاحظوا كلهم قالوا إيش؟ Vascular lesions, صح؟ اللي قبلها قالوا soft tumors of muscle tissue, or most of that is tumors. بس هنا قالوا إيش؟ Synovial disorders. Pigmented villonodular synovitis. It's a common disorder. It's a common synovial disorder. It affects mostly the knee, followed by hip and shoulder. I've never seen hip, I've never seen shoulder, but I've seen knees and I've seen ankles, but it's common. In sequence, knee, hip, shoulder. In big joints. Most of the time, PVNS patients present to you with atraumatic hemarthrosis. يقول لك يجيك دكتور الله تجولي تتنفخ معي ركبتي بدون إصابة بدون حاجة. تكبر وتصغر. So you should always think about it. It's not a disease, it's not a pathology, it's just it's not a tumor, it's not benign, it's not malignant. Often it's not a malignant entity. It's something benign and it's not a tumor per se. It's a synovial disorder. But usually it's associated with pain and is the most common presentation, and radiograph may show cystic erosions on both sides of the joints. ليش؟ لو كان لا سمح الله احنا قلنا synovial disorder, if it stays, if it goes untreated, it can have hemosiderin deposition and hemosiderin deposition inside the knee joint or inside the hip or shoulder. It will erode on the cartilage, and that will end up with arthritis, so that they will have in the end advanced arthritis. أحيانا تشوفوا السلايدز هذه. أنا أخذت السلايد هذا ترى من orthobullet, so it can come at times. It's not common, but again, يكون عندكم whenever you hear the name pigmented villonodular synovitis, you should always consider vascular nevi. You should always think about it. إحنا قلت لكم hemosiderin part of hemosiderin stained multinucleated giant cells and chronic inflammatory cells. تمام. PVNS, villi, hemosiderin. تمام. Again, this is an X-ray for a patient with PVNS. If you can see, you can appreciate that there is a very large soft tissue part over here, and you can see that there are also bony changes over here. Like this is a very late presentation of PVNS. He had undergone a long treatment, and neglected treatment on T1 and T2. PVNS appears low both, low T1, low T2, بس دائما يكون عندهم inflammation. تمام؟ treatment is complete synovectomy. Take out the whole synovium. تمام؟ احنا ليش قلنا low T1 low T2 عشان حتبان زي هذه. هنا دحين تقولوا طيب عندنا شوية هنا. طيب ايش هذا؟ This is not normal. This is abnormal. تمام؟ this is what they say hemosiderin. Okay? فعندنا yes, we do have something in the retropatellar area, and we do have something inside the knee joint, and we do have something in the back, but treatment is usually complete synovectomy, whether arthroscopic, and usually we start with arthroscopic synovectomy for intra-articular part, retropatellar part, and after complete synovectomy is done for the intra-articular part or inside the knee, usually the oncologist comes back, or his role comes in and take out the whatever posterior component are there with a posterior approach to the knee. This is the fun part for me. Other rare sarcomas. Synovial sarcoma usually arises from intra-articular locations. Synovial, you can remember it, synovial sarcoma, synovium usually is inside the joints, so it's common from intra-articular, okay? Most commonly it occurs in the foot. So hand, most common soft tissue sarcoma in the hand is epithelioid. Most common soft tissue sarcoma in the foot is synovial. Sometimes it has mineralization, and it's highly characteristic for soft tissue mass in the foot with calcifications in it. It's concerning for synovial sarcoma. Histology sometimes appears as a biphasic pattern. الكلمة دي دائما تيجي أحيانا. Synovial sarcoma in histology have question mark biphasic pattern. تمام؟ إيش قصدهم biphasic؟ يكون عندهم يعني features of carcinoma and features of sarcoma. تمام؟ فيصير عندك epithelial cells and spindle cells. تمام. طيب خلونا هنا في هذه في البايفيزيك باترن هذه. طيب في احيانا يقول لكم والله it's an MCQ question. افتكره ماني عارف متى جاء الله اعلم، بس انه patient when يعني عنده pathological fracture and the patient was considered for IM nailing, went for biopsy. تمام. Taken it to OR. Biopsy was taken for frozen section and came back as spindle cell. Right. If it came back as spindle cell, you should not proceed with IM nailing. It's considered possibly a sarcoma. تقفل، طلع المريض, work him up, chest, abdomen, pelvis, bone scan, local MRI for the whole extremity, bone scan, وبعدين تشوف البايوبسي حقتك. إذا قال لك والله pathological fracture and it came open or frozen section came back as epithelial cells, proceed. Most likely it's either lung, thyroid, renal, ولا breast, prostate. تمام. This is the question that's very common, and it's a common situation, common scenario that can happen in your practice. تمام. pathological fracture، كلمت الباثولوجي قلت لهم حرسل لكم frozen section، ترسل الفروزن يقول لك والله spindle cell. spindle حتقفل وتطلع المريض وصلى الله وسلم وبارك، stage him, work, do the workup، وارسلوا لي الباثولوجيست وارسلوا لي orthopedic oncologist. والانسجن المفروض يكون صغير، ما تسوي بايوبسي ب 15 سنتيمتر انسجن ولا 20 سنتيمتر انسجن، بايوبسي صغير. تمام. 3 to 4 centimeters كفاية, more than enough. Epithelial, proceed. Spindle, don't proceed. Consider it a sarcoma, send it to someone else. Right. All cells with synovial sarcoma have a translocation. Synovial sarcoma, consider a translocation associated with it is X18, translocation X18. Genes associated with it is SYTSSX1. أنا حافظها بالشكل. In our practice, we don't ask about it, but in your exams, you have to associate X18, synovial sarcoma, SYTSSX. حاولوا تحفظوا, يعني try to have something to remember it with. طيب, stains usually they're positive for keratin, epithelial membrane antigen. ما أعرف how important is this. I've never been, ما أفتكر جات في MCQ, بس it's موجودة في testable concept. طيب, epithelioid sarcoma, most common sarcoma of hand. Lymph node mets is common. Clear sarcoma, clear cell sarcoma, melanin producing lesion, translocation 1222. Lymph node mets is also common زي ما اتفقنا. طيب, post traumatic conditions ليش حطوها؟ دحين نقول sarcoma may spontaneously hemorrhage. تمام, sarcomas can hemorrhage, بمعنى نيجي لهذه السلايد. هذه ايش؟ هذه لايبوما, هذه ميكسر لايبوسايت. طيب, sarcomas can sometimes hemorrhage within the pseudocapsule, بمعنى يصير في عندنا hemorrhaging هنا في الداخل في ذا المكان. تلاقي sometimes the thigh may, let's say, swell post biopsy or post trauma. The patient can have swelling or hemorrhaging inside a tumor. If you see an MRI with a soft tissue mass and the MRI or the radiologist says there's possible hemorrhaging inside the tumor, but nothing is coming out, معناته في عندنا pseudocapsule maintaining the tumor inside, and it can happen either spontaneous or post-traumatic. بس نيجي نتكلم على حاجة تانية هنا. طيب, on advanced imaging of hematomas that do not have facial plane tracking or subcutaneous ecchymosis. طيب, عادة لما الإنسان يتعور ينخبط إيش يصير عنده؟ contusion, bruising, ecchymosis. So this is a normal response. But sometimes, no, the patient does not have ecchymosis or bruising, and he has hemorrhaging, but it's only seen on the MRI, for example. And large mass hemorrhaging inside the tumor, and it's not tracking outside of the muscles. إيش يعني tracking outside of the muscles؟ نرجع لهذه مثلا. No. خلينا في هذه. بمعنى this is within a muscle. تمام؟ Sorry, خلينا نأشر. This is within a muscle. Hemorrhaging is going to be contained within this muscle. It's not going to go to this muscle. It's not going to go to this muscle. No, it's going to stay within the tumor. تمام? If this happens, that means it's possibly a sarcoma until proven otherwise. Okay. Myositis ossificans. أحيانا يكون عندنا difficulties diagnosing myositis ossificans. We have عندنا conventional osteosarcoma, which is osteosarcoma. It's from the bone. It's osteoblastic. فعفوا, it's forming bone. بس أحيانا يكون عندنا myositis ossificans, which is calcification within a muscle. Muscles, they calcify post-trauma most likely. That's why history is very important. History, physical examination, it's very important. So if the patient has history of trauma very recently, and the patient 1 or 2 months later develops a calcification within a muscle, or let's say calcification in the soft tissue, myositis ossificans should be considered in your differential diagnosis. But let's say assume that the patient has no history of trauma and suddenly has calcification within the soft tissue. No history of trauma whatsoever, not even minor. So sometimes patients which is very rare, but can have extraskeletal osteosarcomas. And myositis ossificans, an extraskeletal osteosarcoma or soft tissue osteosarcoma, they are very difficult to differentiate, even with open biopsy. It needs a very expert pathologist, and even then they even struggle with that. بس at your level, myocyte insufficiency عشان تفرقوا يعني something to help you to differentiate between myocyte insufficiency و osteosarcoma paraosteosarcoma مثلا. الميثود of classification. ايش الفرق؟ myocyte insufficiency it's classification within the muscle. تمام؟ فعادة يصير عندهم peripheral calcification. عفوا ايوه peripheral calcification. بس osteosarcomas usually have central calcifications بcentripetal manner. عفوا انه يبدأ من النص ويطلع لبرا. while myocyte insufficiency they have peripheral calcification. خلينا نشوف بس هذه اللي هنا حوريكم osteosarcoma. فين osteosarcoma؟ osteochondroma cartilage. احنا قلنا بوني حتكون فوق. يس هنا. طيب لو تلاحظوا calcification is within يعني بادئ من هنا ورايح على الأطراف. So this is calcification starting from the center of the tumor and going outside. تمام. هذا بس في الإكس راي. غالبا هذا السؤال اللي ممكن تتسألوا فيه. لو كانت بس يحط لكم في الMCQ question غالبا paraosteosarcoma ولا periosteosarcoma حاجة زي كده. بس حاجة bone forming غالبا osteosarcoma. ويحط لكم واحدة من التشويسز myocyte insufficiency. The most common let's say يعني most common thing that you should consider a type of mineralization. إذا كان centripetal manner calcification from within going outside, consider it a tumor osteosarcoma مثلا. تمام. لو كان peripheral calcification consider myocyte insufficiency. خلصت. سامحوني طولنا. ساعة كم؟ أفتح المايك لكم. طيب دحين إذا تبغوا نقدر نفتح المجال للأسئلة. دكتورة مرام تقدر تساعدني؟ مرام أيوة مرام.
إيه هلا دكتور.
إيه دكتورة مرام تقدر تساعديني بالنسبة للأسئلة. اللي عنده سؤال أقدر أجاوب لكم عليه أنا حاضر.
تمام.
طيب في أحد عنده سؤال يفتح المايك حقه ويسأل يلا. إذا ما في أسئلة نقدر نروح للMCQ questions أو نقدر ناخذ practice sessions. أخذ واحد فيكم واحد بما إنكم 9 أنفار بس أو حتى 8 أنفار. 9 أنفار نقدر ناخذ اللي هو how to read X-rays.
أنا عندي سؤال من الجزئية حق المرة اللي فاتت.
قولي.
إيش الفرق بين الباري أوستيال والبيري أوستيال؟ لو في الإكس رايز كيف أقدر أفرق بينهم؟
حطينا X-rays أظن ما خاب ظني هذه. طيب خلينا نشوف. طيب دحين أقدر أرسم لكم أنا صح نسيت. أول ما كنت أقدر أرسم. طيب إيش كانت الكلمة؟ string. طيب الباراوستيال المايك حقي مفتوح؟
أيوة سامعينك.
طيب الباراوستيال it usually originates from let's say for your exam purposes whenever you think of paraosteal think distal femur posterior knee.
تمام.
just على طول paraosteal distal femur posterior knee فينها على طول دوروا عليها. تمام. but for separating this and this usually paraosteal is adjacent juxtacortical. تمام. it's not flush on the bone. ما هي لاصقة في العظم. طيب كيف تعرفوا الشيء ده؟ هنا عندهم شيء اسمه string sign. لو تلاحظوا هنا أقدر أدخل القلم ده. هذه طبعا هذه ما هي dead lateral أو almost dead lateral. في الكوندايز are almost لا يعني parallel to each other، بس يعني في overlap هنا. بس هذه هذه الكوندايل حقت الجهة الثانية، فهنا it's not touching the bone. في عندنا هنا فراغ. This is what they call string sign. الstring sign عبارة عن إيش؟ It's just a sign that tells you that the tumor is not on the bone itself. فنيجي نشوف ايش سويت. طيب مو مشكلة برضو كويس. periosteal sarcoma. طيب periosteal sarcoma جي من البرياستيوم. هنا لاحظي عندك هنا زي كأنها Codman triangle، تمام، and the periosteum is elevated. هذا كله periosteum، تمام. ف if you see the periosteum thickened and it's calcifying، ولاحظي هنا برضو كمان عندك it's going into the bone. ف this is the periosteum reacting، عفوا the tumor reacting to the bone, affecting the bone, and the bone trying to contain the tumor. فإحنا قلنا من أول إنه there's always a push and pull with any bone lesion، تمام. ف 7 questions الأول قلناها it's very important, but there is always two things you should always consider. The tumor is always affecting the bone, and the bone is trying to respond to the tumor. And most likely, most response is what? Most of the tumors are lytic. فتكون let's say يكون الاوستيوكلاست شغالة كتير فأكلت في العظم، تمام. ف the bone is trying to do what? Trying to contain the tumor. How? It's bone. ايش حيصير عنده؟ يا انه يسوي يا انه الاوستيوكلاست تشتغل او الاوستيوبلاست تشتغل. فاذا كانت tumor over activating الاوستيوكلاست، العظم ايش حيسوي؟ Trying to contain it by osteoblast activation.
Okay.
To catch up with the tumor. فبيحاول البريوستيوم is trying to come out عشان يلحق على التومر to contain it in، بس ما هو لاحق. فتلاقي البريوستيوم يطلع شوية ما لاحق، فالتومر أسرع منه. فيقوم إيش يصير؟ الكودمان triangle gets formed. فيبدأ من هنا، بعدين التومر is too quick، فإيش يسوي البريوستيوم؟ طب خلينا نطلع برا نحاول نلحق عليه. ما قدر، طب خلينا نحاول نلحق عليه زيادة. تلاقي الكودمان triangle أحيانا very big، تمام. فالكودمان triangle is the response of the periosteum trying to contain the tumor. And usually sarcomas, they are very rapid in relationship to the bone morphology or bone response خلينا نقول، تمام. لأنه normal people، أنا أنتوا كلنا الله يحفظكم، الأوستيوكلاست is active and osteoblast is active، تمام. This is the normal response. There's always a remodeling process in our body. Osteoclast is always breaking down the bone, and the osteoblast is always trying to build up bone. This is normal. It's happening 24/7. It's always active. تمام. ادونا سؤال تاني. طيب انتوا ما عندكم، انا عندي حاجة. sorry سامحونا. ortho فين حطيته؟ اوكي كتاب قديم، بس اباكم تصوروا لي صفحة واحدة بس. لا خلينا في النظيفة دون الشخاميط. اوكي يس ابغى دي.
7 questions.
سكرين كابتشر. done خلاص كمل.
تمام.
طيب examples ما عاد خلاص في أسئلة، نروح ل طيب نبدأ بما انكم 9 1 1 خلاص نبدأ من فوق. عبد الله
هلا والله.
عبد الله تعال يا حبيبي تعال. سهلة ظريفة حلوة. اقرا عندك التشيت شيت حقتك اللي هي ال7 الأسئلة هذيك، ابغاك تجاوب لي عليها واحد واحد.
So starting, this is an APN lateral view of the left knee of skeletally immature patient, showing a lesion or a mass in the distal femur medial side. A description of the mass itself, it is it has a stalk and a bony cap. It seems to be a benign lesion with no significant periosteal reaction, and I cannot notice any cortical erosions. And there is mild soft tissue swelling surrounding the stalk itself. What else?
خلصت؟
So regarding the question itself, so the questions that I want to answer are the age of the patient. So it's he's currently mature. The location, it's in the right in the left femur, distal femur to be exact, metaphyseal diaphyseal junction. So it's eccentric, going out of the bone. It's anteromedial to be exact. For the matrix, I think it is it's forming a bone, so it's osteoblastic in, regarding the matrix itself. The morphology, it is well defined osteoblastic lesion. I don't know how to comment in the zone of transition regarding this picture. As I said, there is no significant soft periosteal reaction as aggressive or condiment sign or onion peel sign. It's a monolesion. It's only one that can be seen in this radiograph.
طيب خلاص خلصنا؟
Yeah, I think I'm done. Yes.
طيب you did good ما شاء الله تبارك الله. طيب فنحاول نعبي الفراغات اللي ما عرفت تجاوبها صحيح؟
صحيح.
طيب انا افضل الشيت حقتي اللي هي في حد يفتكر لي كان ايه بس لقيت خلاص لقيتها. يس حطيت التشيت شيت اللي اديتكم هي حطيتها قدامي مو بس انتوا اللي تغشوا كمان انا اغش. طيب فاللوكيشن you said it excellent. ف you should always start with غالبا الامتحان حيدوكم one picture, one big large picture. تمام. ف you should always start this is an AP. okay, is there another view على طول AP. طيب انت عارف ان اصلا طول عمرنا في الاورثو AP lateral. طب ايش دخل الامتحان يعني على راسه ريشه؟ ask for the other view. ليش؟ you can always miss very important information. تمام. ask for another view. So this is AP lateral skeletally immature. You said it very nicely. There appears to be AP lateral knee X-ray of a skeletally immature patient showing a bony lesion protruding bony lesion at the metadiaphyseal part and the anteromedial aspect, protruding and what appears to be in continuance with the cortex of the distal femur, in continuity with it. It shows no periosteal reaction, no obvious soft tissue mass, no cortical disruption. طيب الquestions اللي هي 3 و4 what is the lesion doing to the bone? It's protruding out of the bone and continuous with the medulla or the
دكتور أحمد
هذه it's an osteochondroma. ايش ده pathognomic حق الاوستيوكوندروما؟ It's continuous with the medulla. It's always continuous with the medulla. تمام. There is nothing else بالنسبة لهذا الاكس رايز. malignant transformation rate for osteochondroma is less than 1%. اقل من 1% malignant transformation. طيب تفتكروا احنا قلنا في السيشن الاولى history physical؟ انا ليش هنا يهمني in this case specifically history and physical؟ طيب
To feel for the cartilaginous cap.
ايش؟
To feel for the cartilaginous cap.
طيب انا قلت الهيستوري والفيزيكال، الكاب حشوفه في الاكس راي؟
No, history wise you will see the signs, the symptoms that some.
لا انا سؤالي واضح. في الاكس راي حتشوف الكارتلج كاب yes or no؟
No.
No. طيب can you correlate the cartilage cap مع clinical examination yes or no؟
Yes, if it's superficial.
Yes. قول هات اللي
Yes.
عندك.
Yes. Yeah, yes, if it's superficial and the patient is lean, you can feel the cartilaginous cap and its dimension.
لا you cannot. طيب بس انت قربت. بمعنى انا اقرب لك هي زياده وزياده. انا اقول لك كيف تعرف انه has a very thin cap. Whenever you feel an osteochondroma usually they are superficial. تمام. عادة المالجنت ترانسفورميشن احنا قلنا الكارتلج كاب حيكون more than 2 centimeters. تمام. agree everyone agree؟ في بعض الكتب 1.5 centimeter بس let's say 1.5 or 2 centimeters. 1.5 is a very thin very small distance. صحيح؟ فمعناته most adult patients let's say they will have a very thin cap almost paper thin. فلو جاك المريض عنده osteochondroma you can feel a bony prominence في الديستال femur بس تحسها صغيرة. تيجي تشوفها في الاكس راي it's very small. تمام. بس لما تيجي تشوفها والله في الاكس راي مرة صغيرة بس when you examine the patient you can see or feel a very large mass. تمام. كيف كده؟ الاكس راي صغيرة clinically it's very large. طب ايش الشيء الكبير ده؟ It's cartilage. Everything is cartilage. What you feel the large part is cartilage. ممكن المريض يكون عنده cap of 10 centimeter. I've seen it. X-ray it's very small osteochondroma بس تيجي تحسه clinically يا عمي هذه مرة كبيرة. صح ولا لا؟ فهنا when you associate the clinical مع radiological it gives you the picture. حلو؟ وصلت الصورة؟
واضحة.
طيب يلا اللي بعده ادونا مين حيقرا الان؟ خلونا نقفل ده. يلا عبد الله قفل. احد ثاني يفتح. خلاص ما شاء الله باقيكم واحد. الله يديكم الصحه والعافيه. الام سي كيوز ترى ترجع لكم انتم. You want us to answer it now I'm open. محمد يلا محمد واحد فيكم كلكم محمد ما شاء الله. طيب اللي موجود يفتح اللي يبغى.
Yeah, I'm ready.
Go ahead. نعطيك واحدة ثانية. طيب أنا ما جاوبتك على ال
Transitional zone.
أيوة ما جاوبتك على هذه بس حنديك هي. خلينا في هذه ايش رايك؟ يلا روح. طبعا الاكس راي سيبك من البون سكان.
So in this X-ray, we can see that it is an AB view of the right knee of skeletally mature patient, showing an lesion involving the proximal right tibia. It is heterogeneous in nature. First of all, step by step, its location in proximal tibia involving the metaphysis, epiphysis, metaphysis, and part of diaphysis, with also the proximal fibula. So it's it has a soft tissue component. It's mixed osteolytic and plastic in nature. It is ill-defined with a wide transitional zone with a prominent periosteal reaction noted in the medial lateral side. Regarding its effect on the bone itself, it showed that there is a cortical erosion, especially on the fibular side, which seems to be chronic due to rebuilding of the cortex, and the mass itself is pushing it outside. We also see heterogeneous, what I think it's calcification all around. Maybe it's a sunburst appearance.
No, but we'll get to that. الحين نقولها. نعدي على sunburst، نعدي على اليوين، نعدي كمان على الكالفين تراينجل مرة ثانية. أبشر. طيب what you said was excellent. طيب هنا كلامك جميل. حعيد أنا my description يمكن حيكون نفسه بس في small تفاصيل بسيطة فرق. طيب this is an AP X-ray of a skeletally mature patient showing plastic or let's say mixed lesion in the proximal tibia involving the epimetadiaphyseal area with what appears to have an extension into the soft. What appears to have an extension into the soft tissue or an involved soft tissue part of it, أو خلينا نقول epimetadiaphyseal area with what appears to have a ring and arcs appearance of the lesion, mixed with a wide transitional zone and periosteal response in the form of rings and arc formation, and it appears to be abutting and pushing the proximal fibula. Gives rise to possibly a slow growing tumor, and there doesn't appear to have any cortical disruption, and there appears to be a soft tissue component for it. طيب لما نيجي نتكلم على ال transition، لما هنا تقدر تقول لي فين او تقدر ترسم كده بالضبط فين نهاية الورم بالقلم؟ هل ممكن هنا يكون فيه؟ يس ممكن. هل هنا الورم يخلص وهنا ما في ورم؟ I can't tell you. بمعنى الوايد transitional zone بمعناته ما تقدر ترسمه بالقلم، هذا وايد transitional zone. النيرو transitional zone زي هنا عندك نيرو ترانزيشنال زون، اقدر ارسم لك هي كده
واضح.
هذا نيرو ترانزيشنال زون. طبعا الديسكربشن هذا اللي انا بقوله كله it only applies for X-rays not MRI. X-rays only. تمام. هنا برضو نفس الشيء تقدر ترسمها، مع انه هذه باراوستيوساركوما بس تقدر ترسمها برضو. طيب السنبرست appearance او الكادمن تراينجل، هذه كادمن ترى. اذا شفت ايش براحة ما حتروح، ما اعرف كيف اشيلها. ثواني. يس. طيب اذا شفت البريوستيوم going out like this، تمام، زي هذه اللي هنا كده، تمام، فهذا يسموه كادمن تراينجل. الكادمن تراينجل is the response of the periosteum trying to contain the tumor. كل الساركومز they grow very rapidly، عشان كده تكبر بسرعة. إذا كنت تفتكر إحنا قلنا في السيشن الماضية البوني sarcomas they grow very rapidly and they go from inside the bone to outside of the bone, outside of the compartment which is the bone, via hematogenous spread. كيف؟ عن طريق هافرشن كانال.
Yes.
Right. This is an MCQ question. فتخرج من جوا لبرا عن طريق هافرشن كانالز. sarcomas they do respect boundaries, بس المشكلة إنه cortex they don't have to break it. They can go from in to out havisham canals. بس benign aggressive lesions زي الاوستيوساركوما زي مثلا عفوا benign aggressive lesions زي ال ABC or GCT على سبيل المثال، تمام، لازم يكسروا الكورتكس عشان يطلعوا برا. حلو،
واضح. Thus it will take more time than sarcoma.
لا نخش في الوقت. فهذه كودمان تراينجل. حلو، نوريك. طيب هنا عندك كأنها sunburst appearance صح؟
Yes.
طيب فهذه sunburst appearance. هذا كودمان proper كودمان triangle صحيح؟ this is an osteosarc. عادة الكودمان is related to osteosarc, sunburst usually with osteosarc. بس Ewing خليني أشوف لك فيه هنا، أنا أفتكر حاطط إذا شفت قول معايا. أنا كنت جالس أحاول أول أعيد لكم الصور نفسها. هذه الصورة مرة قديمة، هذا من الكتاب اللي دبل ريتكم إياه. أنا متأكد إن هنا فيه، ترى هذه كوندروسات طلعت. يا جماعة معقولة ما في؟ أنت ما شفت معي؟
No, there is. I'm looking also.
دقيقة، أنا يوين حاطط الصورة هنا صح، نسيت في يوين.
It's in slide 98.
يس. يس هنا شايف لاير هذه
Onion peel sign.
يس هي هذه. الانيون بيل ساين ولا الانيون شيب ساين هذه عبارة عن ايش؟ هذا البرياستيوم يسوي طبقة زي قشرة البصل، قشرة فوق قشرة فوق قشرة. الفكرة حقتها عبارة عن ايش؟ The Ewing sarcoma is trying to go out and the periosteum is trying to contain it in. Periosteum is failing and the tumor is going out anyway. تمام؟ عشان كده دائما Ewing sarcoma تلاقي عندها very small bony lesion بس تلاقي soft tissue component حقها مرة كبير. عكس osteosarcoma usually big bony involvement بس soft tissue part ما يكون مرة كبير. Ewing عكس small bony big large soft tissue component.
هذا عشان الايج ولا وش السبب ولا عشان الباثولوجي
هذا بس this is just common. This is usually for Ewing and osteosarc. هذا الريسبونس هذا النورمال appearance حقها وهذا usually what we see in our practice. طيب الترانزيشن واضحة كانت. دحين أوريك الترانزيشن زون حقت البناين مثلا زي هذه أو لا بلاش دي. أنا أحب أضيعك شوية. tumors, chondroblastoma هذه حلوة. chondroblastoma is a benign entity. عادة تيجي في البيدياتريك وعادة تيجي في الإبي ميتافيزيال area. من يوم ما تشوف epiphyseal lesion any epiphyseal lesion طالع في الage. If it's pediatric then it's chondroblastoma versus infection. If it's an adult patient in the early 30s غالبا هذه GCT. لو جابوا لك proximal humerus ولا proximal femur مثلا metaphyseal area extending slightly to the metadiaphyseal area غالبا هذه ABC UBC. تمام. بس انه epiphyseal lesion it's chondroblastoma or giant cell. كلنا نفكر في giant cell or chondroblastoma. pediatric consider chondroblastoma, adult patient consider
giant cell.
تمام. This is a pediatric patient, epiphyseal lesion. أقدر أرسمها كده بالقلم بالمرسام. This is where it is. تمام. This is the lesion. this is a narrow transitional zone. حتى هنا عشان كده مهمة جدا في both views, AP and lateral. I can drive. This is a narrow transitional zone. حلو.
واضح.
طيب الأسئلة إذا تبغوا تقدروا تخلوها بعدين مع يعني ما في عدد، تباني أنا أسويها معاك ما عندي إشكالية، أنا أم فري، بس ما شاء الله أنا شايفكم تسحبوا واحد واحد.
ايوه احسن دكتور، نخليها وقت تاني.
زي ما تحبوا.
الله يعطيك العافية. شكرا
في
جزيلا.
سؤال هنا
واضح بإذن الله.
لو عندكم أسئلة ارسلوا الدكتورة مرام، حتتواصل معايا، عندها رقمي تقدر تدي لكم إياه. ربنا يوفقكم إن شاء الله يا رب، وإن شاء الله بالتوفيق يا رب.
الله يسعدك دكتور.
يعطيك
والله.
العافية. شكرا جزيلا.
الإكزام حقكم بالنسبة للأونكولوجي try to be safe. بمعنى the whole test is to test how you think, how are you a safe surgeon or not. تمام. كل الإكزام they want to tell you that how to approach a benign patient and how to approach a malignant patient. تمام. الفكرة منها إنه كيف تعرف إنه هذا ممكن يكون aggressive or malignant. تمام. في كل الأحوال حتى لو وصلت إن شاء الله بعدين كسينيور كلينيكال إكزام حتخلصوا إن شاء الله بإذن الله، هحول المريض للأورثوبيديك أونكولوجيست. طيب حيقول لك أنت الأورثوبيديك أونكولوجيست what's your next step. حيكون عندكم الجنرال بيكتشر، الجنرال تريتمنت بلان حقت whether benign or malignant you should know it، بس should you do it no unless عاد ربنا كتب عليكم ودخلتوا أونكولوجي، عاد الله يكون في عونكم.
ان شاء الله باذن الله يا رب.
طيب الله يوفقكم ان شاء الله يا رب. تمرون اي حاجه؟
الله
سلام.
يعطيك العافيه يا
الله
رب.
يعطيك العافية.
يلا الله يوفقكم ان شاء الله يا رب. فما مع السلامه.